Okay, the next H is up. Hypo and hyperkalemia, and this speaks to the amount of potassium in the bloodstream. Now, a normal potassium level is between about 3.5 to 5 milliequivalents per liter. That's a normal potassium level. Let's start with hypokalemia, too low of a potassium level. Now, how does this happen? Well, the literature, the AHA literature, really suggests GI loss is probably the #1 cause. Diarrhea. When they're having diarrhea, they're losing potassium. This can come through excessive laxative use or just a history of profound diarrhea. So they're losing potassium. Another thing is diuretics. Remember, when you're peeing out potassium. So people that may be taking diuretics for weight loss or abusing diuretics for weight loss, as they're diuresing, you're losing potassium. Now, one of the big issues with hypokalemia is that we cannot replace potassium quickly in the body. You can't just bolus someone with potassium chloride. In fact, that's the drug we give for lethal injection. So every time you're hanging potassium, you want to show some respect because that's the same drug we use for lethal injection. So potassium cannot be administered quickly to treat hypokalemia. The general infusion rates between 10 and 20 milliequivalents per hour for hypokalemia. The max dose they recommend in the literature is you can take 40 milliequivalents of potassium in a liter bag of 0.9 and administer that over an hour. So you're giving your 40 milliequivalents plus a liter of saline. So you're giving them some fluid with it. But that's the max dose we want to give when we're replacing potassium for hypokalemia. Again, you cannot replace it quickly. Another risk, patients that have been admitted for acute MI, just being hypokalemic puts them at a risk for developing ventricular fibrillation. So if you're on a transport team and maybe you're moving a cardiac patient to the cath lab, it's not uncommon to see a K-rider or some potassium hanging with that to make sure they have an adequate potassium level. Next, hyperkalemia. And of all the electrolyte disturbances, the one most likely to kill your patient is hyperkalemia, too much serum potassium floating around in the body. Who's going to develop this? Renal patients, your dialysis patient that hasn't been dialyzed. Now, one tip for detecting hyperkalemia is you look at your ECG tracing and you're going to notice peaked T waves. That's one of the first signs on an ECG that the serum potassium, their free serum potassium, not in the cells, extracellular potassium is starting to rise. You're going to see a widening of the QRS. You're going to see heart blocks develop, and from that point on, they're at a very high risk for developing cardiac arrhythmias, ventricular fibrillation, and that's the big risk. Now, the treatment for that? For acute hyperkalemia with peak T waves, we're going to administer calcium chloride. And the recommended dose would be 5 to 10 mLs of 10% calcium chloride. And what this does is it helps to stabilize the action potential in the cell so the cell is less likely to develop a lethal arrhythmia. Continuing on, we can administer bicarb, right, to treat the acidosis. We can administer glucose and insulin to help push the potassium back into the cell. Another treatment is a continuous nebulizer of albuterol. That beta-2 agonist can also help to force potassium back into the cell. So we're talking about hyperkalemia. Now, where else can you see hyperkalemia? Well, diabetic ketoacidosis, right? Anytime you're acidotic, you have a rise in your potassium. What? Yeah, anytime you're acidotic, you're going to have a rise in your potassium. And here's what happens. Potassium is your primary intracellular electrolyte. It's a positively charged cation. Hydrogen is also a positively charged cation, but it has a greater charge than potassium. So here's what happens. You become acidotic, and acidosis is an increase in circulating hydrogen. So now you have this increase in hydrogen in the body, and this hydrogen wants to spread out and be equal both extracellular in the bloodstream. And it literally goes into the cell and it kicks the potassium out. You have an increased serum potassium level. That's bad. As long as the potassium's inside a cell, it's kind of hidden from the other cells. But as soon as it leaves that cell, is in the intravascular extracellular space, the other cells can pick it up, including the heart, which is bad. We don't want the heart having too much potassium. Now, in DKA, remember the problem is really an insulin problem. The body's not producing enough insulin, not making any insulin, it's resistant to the insulin, whatever it is, but it's not allowing that sugar to enter the cell. So you have all these sugar particles in your bloodstream, intravascular space. This creates an osmotic shift. Remember, all these particles are going to start pulling fluid inside the intravascular space. Then the kidneys see this and they go, what's with all this fluid? Let's get rid of the fluid. So as they start getting rid of the fluid, diuresing, this DKAer with this elevated sugar is starting to diurese and lose potassium. So they're really losing volume, they're dehydrating, and they're peeing off potassium. So you have a DKAer come in, and you look at his sugar's really, really high. We're gonna give him fluids. We look at his potassium level, and his potassium level's normal. It's fine. Is it?
It's fine.
It was a yes or no question.
Okay, yes, it's fine.
This is a double-edged sword of DKA. The diabetic ketoacidosis. So they were diuresing because of the increased sugar levels. They diuresed, they lost potassium, but they were acidotic. And the increased hydrogen concentration falsely elevated their potassium to a normal level. Therefore, if we fix this acidosis, their potassium is going to drop. And remember, we can't replace potassium quickly. So it's not uncommon when treating DKA, we're giving them lots of fluids, but if their potassium's normal, we have to start a potassium rider. We got to start replacing that potassium because as we correct the acidosis, we're going to shift the potassium. Make sense? I'm Mark. Thanks for watching. See you in the next video.